This is actually a pretty fun topic, and my goal here is to obviously provide a review for many of you, but also prepare the fellows for what they would be seeing on a test. So hopefully this is helpful for everybody. So when I started my residency over 20 years ago, if a patient came into the ER and was diagnosed with a DVT, I just treated them, and that's what I was trained to do. That's what I was told to do, and we didn't really question that. Okay, we just did what we were told, and essentially we started it on heparin, and then we transitioned them to warfarin. But why do we anticoagulate, and what's the evidence for its effectiveness? What's the significance of this? Well, VTE is the third leading cause of cardiovascular death and disability worldwide. Untreated, proximal DVT advances to PE 26 to 67% of the time. Recurrent thrombosis, if untreated, occurs 29 to 47% of the time. Now, if you treat it, recurrent thrombosis actually drops down to 4.7% or to 7.1%. That's an 80% reduction. So the first takeaway that I want everybody to walk away with is that anticoagulation is very effective, but it's not perfect. So the next question that everybody should ask is, does anticoagulation prevent PE in patients with a DVT? To get the answer to this, we looked to a Canadian study by Duquetis and Ginsberg, in which they looked at standard heparin therapy in 4,221 patients with DVT. And they found that if you treat them by anticoagulating them, then their risk for fatal PE drops down to 0.4% and 0.3% during and after treatment. And in patients with PE, the study had 1,302 patients. Fatal events decreased by 1.5% during treatment. And if they made it through treatment, that risk dropped down to 0%. So the answer is yes. Anticoagulating a patient with DVT is extremely effective at preventing a PE. So to understand how the DOACs work, the direct oral anticoagulants work, we have to review a little bit of the pathology and the science behind how we clot and how some of the more traditional anticoagulants work. There are three parts to clotting in hemostasis. There's vasoconstriction, platelet plug formation, and clot formation. Primary hemostasis is the platelet plug formation part, and secondary hemostasis is the clot formation, or the events of the coagulation cascade. So what happens in primary hemostasis? There's an endothelial lining that gets injured, which exposes the underlying collagen. Embedded within that collagen, there is something called von Willebrand's factor. I'm sure you guys have all heard of that. Von Willebrand's factor is very attractive to platelets. These platelets actually will, as they circulate through the bloodstream, they have receptors called glycophosphate 1b receptors, which actually attach to the von Willebrand factor. The platelets then get activated and release ADP, serotonin, cytokines, thromboxane A2, causing other platelets to assemble at the site of injury. As they assemble, the next step is platelet aggregation, which occurs as platelets collect in large numbers. They become even more adherent to each other. This releases cytokines, which secretes neutrophils, monocytes, increasing aggregation further. The plug that is formed here is a very loose plug. It's a very unstable plug, but it's enough to just stop the bleeding temporarily. One more important thing that happens here is that the negative surface of the platelets, as you form the this platelet plug forms, as they aggregate together, the outer layer of that forms a negative charge. Okay, and that negative charge activates factor 12, and we'll actually kind of go through that why that's important. So the most important thing that you guys need to know here is that two parts to hemostasis. Primary hemostasis is the initial platelet plug, and the drugs that affect primary hemostasis are aspirin and Plavix. So when we talk about secondary hemostasis, we're referring to the events of the coagulation cascade, okay? The goal of secondary hemostasis is to stabilize the platelet plug. So you form that platelet plug from the very beginning, from that primary hemostasis, and now you're gonna go ahead and form a weaving meshwork of fibrin to cement the thrombus, And this is part of what this is the whole part of clotting that DOACs work on. They form, or they either block the fibrin formation in the coagulation pathway cascade. And there's a picture of the fibrin meshwork that intertwines the platelet plug. So there are three main parts to the coagulation cascade. There's the extrinsic pathway, the intrinsic pathway, and the common pathway. Okay. Again, the goal is to activate these coagulation factors to create the end product of the pathway, which is fibrin. And what does fibrin do? It helps to cement the platelet plug to stabilize the clot. So this is just the coagulation cascade again, but we're going to go into a little bit more detail. So tissue factor 3 is released when there's damage to a vessel wall. It activates factor 7 to 7A. Factor 7A combines with factor 10 and activates it. The intrinsic pathway starts off with factor 12, and factor 12 is also called Hageman's factor. That gets attracted by the negative charge of the platelet plug. It gets activated by factor 11. Factor 11 combines with factor 9. 9 and 8 together form factor 10 or activate factor 10. Factor 10A along with factor 5 activates prothrombin into thrombin, and thrombin converts fibrinogen from a soluble state into an insoluble state by forming a bond between all of the fibrinogen molecules. So this is where all the drugs work to block off the pathway. Warfarin works by blocking factors 2, 7, 9, and 10. Again, we'll go into this in a little bit more detail. Heparin works by blocking factor 2A and 10A. Factor 10A inhibitors work by, just like as the name implies, by blocking factor 10. And direct thrombin inhibitors block factor 2A, thrombin. So the way I remember this, just to make it easy for you guys, you start off by thinking, well, what's in the extrinsic pathway? Well, 7 has 2 E's in it, so that makes it the extrinsic pathway. Okay, 3 and 7 add up to 10, so X marks the spot. X is going to be in the middle. That's the extrinsic pathway. And then when you start off with the intrinsic pathway, you know that you start off with 12. You go down to 12, 11, 9, and 8. You skip 10 because 10 is going to be X marks the spot. Okay. And then the common pathway is built out of 5 times 2 equals 10 times 1 equals 10. So that gives you the simplified coagulation pathway. All right. And you remember that the extrinsic pathway is measured by PT because there's only one T. Tennis is played outside, and table tennis is played indoors. So PTT is indoors, and that's part of the intrinsic pathway. And that's how I remember it. So let's talk a little bit about the traditional anticoagulants. Warfarin, heparin, low molecular weight heparin, fondaparinux. So warfarin is a vitamin K antagonist. It works by blocking clotting factors 2, 7, 9, 10. Does so by decreasing the activity of an enzyme called VCORC1, vitamin K dependent enzyme. Some downsides to warfarin include it requires strict laboratory monitoring. It's unpredictable pharmacologically. It has unpredictable pharmacokinetic responses. It has serious bleeding complications. Definitely has a prolonged half-life. And it's got a long onset of action, thus the necessary for bridging. Another traditional blood thinner is heparin. The negatives to heparin include a bleeding rate of 10%, whether it's minor, major, or fatal. Heparin is associated with thrombocytopenia, osteoporosis, alopecia, especially if you're on it for long term. It requires IV administration, and there's a need for frequent monitoring. All that being said, heparin is a really cool drug, and the idea behind how the DOACs work is really based on the same mechanism of action as heparin. And we'll go into that in a little bit more detail in the next slide. So heparin works by blocking both factor 10A and thrombin. How does it do that? Heparin is a molecule that's naturally occurring in the body. Everybody has it, right? But we derive the drug from a porcine source, but it's a natural anticoagulant. It's actually free flowing, and it's actually made up of two molecules. Okay, and if you look at that red box up there, so the two parts to heparin include the pentasaccharide, which is 5 saccharides linked together to form a pentasaccharide base. And then there's a purple tail there called a GAG, or glycosaminoglycan. Okay, and the whole difference between whether it's unfractionated or heavy, high molecular weight heparin, I should say, and low molecular weight heparin is based on how long the GAG is, how long the glycoside tail is. Okay, the long tail actually blocks both factor 10A as well as thrombin. And then with low molecular weight heparin, because the tail is smaller, it only blocks factor 10A. And we'll talk about why that's important. So the way that heparin works is it combines with a protein called antithrombin 3. Okay. And antithrombin 3 is made in the liver, and it helps to inhibit clotting. All right. Heparin, it potentiates the effects of antithrombin by taking up factor 10 and thrombin. So the clinical point to this, though, is that the way that heparin works is that if there's no antithrombin, guess what? Heparin's not effective. What conditions can prevent heparin from working properly? Well, liver disease. So if you got bad liver, then it's not going to produce antithrombin. And the second clinical correlation is that patients with kidney disease, right? Nephrotic syndrome, patients that are spilling protein into the urine, they're going to be losing antithrombin. So these patients, if you give them heparin, it's not going to be as effective in a patient that does not have these clinical issues. So we talked about a little bit about the difference between heparin and then the challenges with low molecular weight heparin. It includes an improved pharmacokinetic profile, but again, it doesn't block the thrombin. It only blocks factor 10. The half-life is not dose dependent. There's less antiplatelet activity because of the fact that it doesn't block the thrombin. There's more constant anti-factor 10A inhibition, less protein C antigen decrease, less complement activation, less inhibition of platelet aggregation. But it does require subcutaneous administration. But the good news is that there's no need for monitoring, except obviously in patients with renal failure or patients with morbid obesity and pregnancy. So fondaparinux, I'm sure you guys have heard this, and not many of you guys have actually ordered it, but it's a synthetic pentasaccharide that's identical to the antithrombin 3 binding site of heparin. So essentially, it is the pentasaccharide segment without the GAG. And remember, if you don't have the GAG, then you're not gonna have any thrombin inhibition. So fondaparinux potentiates antithrombin 3 just like Lovenox and heparin. It can be used in HIT patients, heparin-induced thrombocytopenia. However, it's not FDA approved for this. The importance of fondaparinux has been associated with reduced major bleeding events and improved survival compared with low molecular weight heparin. And in large randomized clinical studies, patients with ST segment elevation, these patients had much less bleeding risk. Patients that were put on fondaparinux, lots of studies have been done on this. For prophylaxis for major orthopedic surgery, the risk reduction was 55% for DVT. In ICU patients, general medical patients, the risk for VTE dropped by 10.5% down to 5.6% on fondaparinux. For major abdominal surgery, prophylaxis with fondaparinux has been shown to be pretty significant as well. And then for extended prophylaxis in patients with hip fracture. But what's the main reason why we talk about fondaparinux? We talk about fondaparinux because of this, the Callisto study, okay? And I think Eddie did a great job of presenting this last week, so I'll kind of skip through it real quickly. But essentially, fondaparinux was the treatment of choice for superficial vein thrombosis in patients during the Callisto study. These are patients that had thrombophlebitis in the GSV and SSV, not for varicose veins or the tributaries. Clots that are at least 5 centimeters long and at least 3 centimeters from the junction. had a 5 times improvement in parameters with regards to symptomatic extension as well as symptomatic improvement. So let's go into the meat of the talk. So let's talk about the new and the alternative agents that are out there. Okay, so when you talk about the novel anticoagulants, there are 2 groups. There's the factor 2 inhibitors and the factor 10 inhibitors. Those are the 2 major groups. Factor 10 inhibitors include apixaban, rivaroxaban, and edoxaban. And the key to remembering this is that for the generic name, the apixaban, rivaroxaban, edoxaban, they all have an XA in there. Okay, direct thrombin inhibitors include dabigatran, bivalirudin, and argatroban. Dabigatran is an oral agent, whereas bivalirudin and argatroban are IV meds. How do they work? Well, factor 2 is a thrombin, and factor 10, actually, factor 2 is thrombin, and factor 10A convert prothrombin to thrombin. So both of these block or create fibrin, right? Remember, fibrin is the main end product of the coagulation pathway. So if you're going to block factor 2 or block factor 10, guess what? You're going to stop that coagulation effect. So why is blocking thrombin such an important process, right? We talked about the fact that yes, it does block the fibrin, okay? But what else does it do? It also activates factor 5. So remember that coagulation cascade that we talked about at the very beginning. If factor 5 is required with factor 7 to activate factor 10. Third, thrombin also activates factor 8, which along with factor 9 helps to activate factor 10. And finally, thrombin activates factor 13. And we didn't really talk about factor 13 so much just yet, but it's involved in cross-linking the fibrin to stabilize the clot. So you can see all of these effects. If you block thrombin, you wind up blocking a lot of you get very powerful anticoagulation effects, okay? Now, the important part for everybody to understand, though, is that because if you're going to block factor 10 as opposed to a direct thrombin inhibitor, you're going to block higher up in that chain, and therefore the effects are much more amplified. So if you're going to block individual thrombin molecules, you're not going to get as much of an effect as if you're going to block higher up in that chain, because every factor 10 that produces a thrombin is going to be much more amplified. So blocking higher up in the chain gets you much higher effects, much better effects. So there are a couple really important papers that everyone should know when you're talking about novel anticoagulants. This is the first one, Einstein and Einstein choice clinical trials. So these are the studies that gave approval for rivaroxaban for treatment of deep vein thrombosis as well as pulmonary embolism. And they came from what we call Einstein DVT and Einstein PE trials. The extended secondary prevention of recurrent VTE came from Einstein EXT or extension, and then for PE, Einstein choice. The dosing was 15 milligrams BID for 21 days, then 20 milligrams QD. This was found to be effective and a safe alternative to standard anticoagulation for the treatment of DVT and PE in a broad range of adult patients. In Einstein EXT and Einstein choice trials, rivaroxaban was found to be superior to placebo as well as aspirin. And in fact, 10 milligrams or 20 milligrams, either one, they actually studied both of rivaroxaban for 1 year after 6 to 12 months of treatment, reduces the risk of recurrent VTE by about 80% without significantly increasing the risk of bleeding compared to aspirin. Both Einstein DVT and PE were both open label trials that compared rivaroxaban with enoxaparin following with warfarin for the treatment of DVT. Both Einstein DVT and Einstein PE proved to be non-inferior to enoxaparin and vitamin K or warfarin for the treatment of DVT and PE. And the risk of clinically significant bleeding was similar between treatments. The rates of major bleeding were significantly reduced by approximately 50% for rivaroxaban compared to enoxaparin and vitamin K antagonists. And when you talk about the definition of major bleeding, this was considered clinically overt bleeding associated with a decrease in hemoglobin level of at least 2 units, or bleeding leading to a transfusion of at least 2 units of whole blood, or if bleeding was intracranial, retroperitoneal, or in another critical site that led to death. So the Einstein pooled analysis included 8,282 patients, but what they did was they broke down the patients into subgroups looking at extreme body weight, age over 75, patients with high risk for recurrent VTE, and patients with major bleeding, or patients with creatinine clearance less than 50. Okay, and the sub-analysis showed that there was consistent efficacy of a fixed dose of rivaroxaban versus enoxaparin and warfarin for the prevention of recurrent VTE with reduced rates of major bleeding. Results of the sub-analysis, however, in patients with cancer suggest that rivaroxaban is a good alternative to short course of low molecular. It suggests that, right, that it's okay for a short course of low molecular weight. I'm sorry. So the results of the sub-analysis in cancer patients suggest that rivaroxaban is a good alternative to a short course of low molecular weight heparin, followed by vitamin K. However, it was limited because rivaroxaban was really not compared directly to low molecular weight heparin. So there's suggestive evidence that it's a good alternative, but there was no direct studies done for the analysis. So given that randomized controlled trials have strict eligibility criteria and have very constrained methodologies, you know, how effective is Einstein at predicting real world evidence for these drugs? Well, that enter Zalia study. So the Zalia study is the largest prospective real world study of the use of a DOAC for the treatment of VTE. It's a multi-center, prospective, non-interventional study of patients with DVT treated with rivaroxaban or standard anticoagulation, which was enoxaparin and warfarin. This study enrolled 5,142 patients in Europe, Canada, and Israel. Patients in the rivaroxaban cohort had a lower baseline risk profile than those receiving standard anticoagulation. However, after you do the propensity score adjustment to the incidences of major bleeding, recurrent VTE, and all-cause mortality were similar between rivaroxaban and standard anticoagulation cohorts, and consistent with the results of the Einstein DVT study. Just like Einstein for rivaroxaban, apixaban is not to be outdone, and its study is known as AMPLIFY. AMPLIFY was a randomized double-blind study comparing apixaban at a dose of 10 milligrams BID for 7 days, followed by 5 milligrams BID for 6 months, compared with conventional therapy, which was, again, enoxaparin and warfarin. This study included 5,395 patients with VTE. What they found was a fixed dose of regimen of apixaban alone was non-inferior to conventional therapy for the treatment of acute venous thromboembolism, and also was associated with significantly less bleeding. So this is one of my favorite slides when we talk about the effects of prolonged or chronic VTE management. When you look at aspirin, there's benefit to aspirin. Okay, so that was proven out with Aspire and Warfaza. But essentially, there's about a 30% risk reduction for recurrent VTE. But when you look at warfarin and then the DOACs, you get about an 80% reduction in recurrent VTE. So that's pretty significant. So for your patients that have had a DVT or had some type of thromboembolic event, putting them on something is going to be well worth it. The studies have shown, though, that the DOACs are definitely much better from a clinical effectiveness, as well as a risk reduction in bleeding compared to aspirin. But if a patient says, look, I can't afford it, there's some benefit to aspirin as well. What about the pharmacology behind these drugs? Well, Pradaxa is a thrombin inhibitor, so it's got a different target. It's the only one that's a prodrug, so it enters your body and has to be metabolized into the drug itself to block thrombin. Talk about dosing. Xarelto and Savesa are the only two that are once-a-day dosing. So you have a patient that you're concerned about compliance, you may want to choose one of these drugs. If there's a patient with renal issues, you may want to choose one that has less renal clearance. The effectiveness and safety profile and the pharmacological benefits of these drugs leads us to the 2021 ACCP guidelines, the American College of Chest Physicians guidelines. They favor the new oral anticoagulant agents for acute VTE in patients without cancer. And they recommend a low molecular weight lead-in for dabigatran as well as edoxaban, and obviously a single drug treatment for rivaroxaban and apixaban. However, they do favor low molecular weight heparin over warfarin or the new anticoagulants for cancer-associated acute VTE at least for the first 3 months, and that's a grade 2C recommendation. But it's certainly reasonable to continue initial anticoagulation beyond 3 months of therapy if needed. So how do you monitor these drugs? Well, with factor Xa inhibitors, you can order a PT, but that's not terribly accurate. You can also order an anti-factor Xa activity, but again, not many labs do it. And by the time you get it, it may not be clinically relevant. For dabigatran, the test to order is a dilute thrombin time. Again, not routinely run, so it may be there might be some difficulties getting it back in time. What about reversal agents for these drugs? So praxibine is a monoclonal antibody for inhibiting dabigatran. You can see the red is the baseline for a normal patient. The gray is going to be dabigatran plus a placebo. And then the blue is the dabigatran with praxibine. You can see the activity level drops down immediately, pretty quickly within a few minutes of the administration of praxibine. The challenges with praxibine, though, is that the last time I checked, the cost is somewhere between $3,000 to $5,000 for the dose of this. What about andexanet alpha, which is sold under the trade name of Andexa? This is a recombinant modified human factor Xa protein. Again, it's indicated for patients with life-threatening, uncontrolled bleeding on factor Xa inhibitor meds. Very effective as well, but they're obviously cost prohibitive. What about some of the newer drugs on investigation, which include aripiprazine, which is an antidote for several types of anticoagulants, including factor Xa inhibitors, heparins, low molecular weight heparins, fondaparinux. Essentially, it blocks everything under the sun. And as already mentioned, this is currently in multiple phase 2 trials, which is in progress. And then when we talk about the universal anticoagulant reversal agent, that's going to be your prothrombin complex concentrates. Many of us in the ER use fresh frozen plasma, but if you have the availability of prothrombin complex concentrates, this is about 8 to 15 times more powerful or more effective than fresh frozen plasma. It also can be given very quickly. It can be given within a minute as a bolus, as opposed to fresh frozen plasma, which requires an infusion over an hour or so, or even longer. So what happens when you get bleeding on these medications? How do you manage this? So in general, the post-marketing studies support the findings of the randomized control trials. The majority of major bleeding events were GI, and they had low mortality. Intracranial hemorrhage was extremely rare, but obviously had a very high mortality. So if you're going to have a major complication, it's going to be bad. But in general, most of the bleeding can be managed supportively. Okay, and so this is a chart that came from Juice Van Veen Sheffield Teaching Hospitals, and you can see here that with mild bleeding, and essentially that's going to be your bruising, a little bit of bleeding from your gums, you really want to just hold the dose hold the next dose. If you get more significant bleeding in areas where you can compress, you definitely want to compress that. You want to get your laboratory monitoring, check their renal clearance, check their hemoglobin, check their crit. Consider giving blood if you need to. If they're on dabigatran, you may want to consider dialysis or giving praxibine. And then for major bleeding, you want to consider PCCs or fresh frozen plasma here. So with all of these agents, how do you choose, right? How do you make the determination between what to use? Well, if you're concerned about renal clearance, you're going to want to use apixaban. That's going to be the best choice. Good second choice is going to be rivaroxaban and edoxaban, but you definitely want to avoid using dabigatran because it's got the most renal effect on there. If you want all oral therapy and you don't want to have to bridge them, then you definitely want to use Eliquis or Xarelto. Dabigatran and edoxaban require heparin bridging. If you're concerned about GI bleeding, there's some data out there that the apixaban is going to be better than dabigatran or warfarin. For sure warfarin, but definitely some data out there that apixaban and rivaroxaban are going to be better for you. And then if we're talking about compliance, then you want to use a once a day medication rather than a twice a day medication. So let's go into a couple of cases here to finish out. So if you have a 50-year-old male who presents to your office for acute left leg pain for 2 days, the leg is swollen, tender, red, and warm. There's been no trauma. The exam is consistent with a non-toxic, no acute distress male patient, normal exam, with the exception of a positive Homans in the left leg. The patient is neurovascularly intact. Past medical history includes a DVT. Social history is negative. He currently is on Xarelto. You order a stat ultrasound in the office, and it shows an acute thrombus in the left superficial femoral vein. Okay, what's your recommendation? So a couple points here, okay? The fact that he's already on Xarelto, all right? The fact that he's stable, his vital signs are stable. He's in no acute distress. He's neurovascularly intact, so there's no concerns about an arterial event or any other concerns. We think that this is the cause of his issue, which is the thrombus in the left superficial vein. Okay, so he's on Xarelto already, and now you have a clot in the superficial vein. So the second thing you want to know is that is the superficial vein a deep vein? For many people, I've talked to so many primary care physicians, they think the superficial femoral vein is a superficial vein, but we all know that this is a deep vein and obviously it needs to be treated. He's already on Xarelto 20 milligrams. What is your next step? Okay, continue the current. Okay, recommend taking Xarelto with food. Stop the Xarelto and switch to Coumadin. Add Coumadin to his regimen along with the Xarelto. Okay, so we know that he's stable. We know that Xarelto is extremely effective at preventing DVT. When you go back and talk to him again, you find out that he takes it on an empty stomach. So what we did here was we said, hey, you know what? Let's recommend taking Xarelto with food. Do a close follow up with him. Have him come back in 1 week to check for progression, and we go from there. So the correct answer here is going to be B. And this question, by the way, was on one of the boards, one of the AVLS board exams is knowing that Xarelto should be taken with food. Let's look at case number 2. 43-year-old male patient presents for a 3-month follow-up after being diagnosed with a DVT in the popliteal, perineals, and PTVs in the left leg. He is currently on Coumadin by his primary medical doctor. Initially, his clot occurred 3 months ago after getting off of a flight from Europe and developing left calf pain on the way home from the airport. Scan today shows clearing of the clot in the popliteal, perineals. He continues to have a chronic clot in the PTVs. So, past medical history is negative. Social history is negative for tobacco. The patient is a contractor and travels every week internationally. Okay. So important points here. So he has a known reason for his clot, right? He got off of a plane from Europe. The fact that he's continuing to travel, so he's got a consistent or recurrent risk factor for developing another clot. He's gone through 3 months of treatment and he's gotten better. What's the next step here? Okay. You want it's certainly very reasonable to is it reasonable to stop his Coumadin? He's already 3 months into this and say he's good to go. Don't think I would do that because of his risk for recurrent clots, especially if he's going to continue traveling. And we all know that even if he doesn't travel, the risk for recurrent clot is about 25 to 45%. without any treatment, you're able to reduce that risk by about 80%. So personally, if you've already had a significant clot, then I would personally recommend putting them on something. Would you continue Coumadin or switch to a NOAC, extended therapy? I probably wouldn't do both. So B would be out. C is DC the Coumadin and switch to an aspirin. Very reasonable. That gives you about a 30% risk reduction. Or D, continue full dose anticoagulation with Coumadin for 6 months. I think C is going to be your best answer here, but the best, C is going to be the best answer here. I was going to say B for a second, but it says to continue Coumadin. So C is going to be your best answer because you want to stop the Coumadin. You want to switch to some type of long-term therapy, whether it's aspirin or a NOAC. I would say a NOAC is going to be better because it gives you an 80% risk reduction, whereas aspirin gives you a 30%, but at least C is going to give you a 30% reduction here. So that's going to be your best answer. Let's do one more question here. You're on call and a referring physician calls you for a curbside consult. Her 80-year-old father just was diagnosed with a femoral vein DVT from mid to distal. He is asymptomatic regarding chest pain, shortness of breath, palpitations, or syncope. He complains of mild pain and swelling to the left leg, but it's not horrible. His past medical history includes hypertension, diabetes, hyperlipidemia, and gastritis. Social history is negative, allergies negative. She asks for your advice on what drug is best for him. A, Lovenox and then Coumadin. Patient has too many risk factors, needs to be able to reverse. We all know that Lovenox and Coumadin have worse bleeding risk factors, and we also know that patients tolerate the NOACs pretty well. And we also know that if you had to reverse it, you can reverse it. Obviously, a lot of times the type of bleeding that you get with the NOACs and the DOACs are mild to moderate, which can be controlled with mild compression or holding a dose. So probably A is not going to be the right answer. B, aspirin, because he's got a complicated medical history. He could benefit from aspirin, prevents MI and strokes and less chance of bleeding with a history of gastritis. Probably not. That's definitely not going to be the right answer as well, because aspirin is not going to be the standard of care for a patient with an acute DVT. C, NOAC. Well, Eliquis, yeah, this is going to be a good answer. This looks good because Eliquis, we don't know what his renal clearance is. He's got hypertension, diabetes, so he's probably got some form of renal insufficiency. The likelihood and the fact that it's a curbside where you're not actually able to see him, he is stable. I think it's certainly very reasonable to go ahead and start him on Eliquis. And then D, do nothing for now. He's relatively asymptomatic and you can wait until Monday to get seen by one of your partners. So we're going to avoid that one and go with C. So in summary, there's lots of new pharmacotherapies out there. It's important to know the advantages and disadvantages of each one. It's important to have a basic knowledge of the coagulation pathways in order to understand the mechanism of action. The guidelines for management of VTE are constantly changing and very complex. It's important to know the data that supports the usage of these new class of drugs. Thanks, everybody.
Thank you, Ken. That was really awesome. I mean, for the fellows, I don't know if you appreciated how comprehensive that talk was. Ken's absolutely right about the pathways. You need to know the pathways for when you sit for the boards. You will see at least 5 questions on the anticoagulants and pathways. The other thing that's a frequent question is the renal clearance aspect that Ken brought up as well. So I have a couple of questions, Ken. So there are things that, since the studies have been done, the Einstein studies, where we have some new kind of, I guess they're clinical observations more than anything else. So I found that with apixaban, the most common complication is actually headaches and diarrhea and sometimes nosebleeds. So when I've gone back and I spoke to the reps and I looked up the additional information, actually headache on the IFU is the #1 complication with apixaban. So for the fellows, we're often talking about major bleeding and risk factors, but if your patient comes back and they tell you they have intense headaches, the recommendation is actually to stop the apixaban at that point. So Ken, what do you tell your patients who come to you and say, listen, I have to go to the dentist and the dentist wants me to kind of, hold the apixaban or the Xarelto, or I have the gastroenterologist who wants me to hold it. I get some of these guys that want me to hold it for 3 to 5 days beforehand, and I think that's absolutely ridiculous given the fact that the half-life is 12 hours. So what do you tell your referring docs and want you to hold the anticoagulants?
No, that's absolutely. I'm with you. I tell them to hold it for 24 hours, and I tell them that once they're done with their teeth cleaning or their procedure, they can restart it again the very next day. So there's absolutely no reason to stop it for more than 24 hours.
Yeah, I do the same thing. I tell them usually hold your evening dose and hold your morning dose, and then restart your evening dose, which would be the 24 hours, like you said as well. But holding it for 3 days, in my opinion, actually has greater risk factors because there's some concern that you may get a hypercoagulable effect when you stop it acutely and then leave it off. So you may actually be putting them at risk for getting a DVT by holding it that long.
Yeah, yep, agreed.
So the other thing is for the group, have any of you noticed that the new oral anticoagulants seem to have a significant anti-inflammatory effect compared to like Coumadin or heparin? Because I noticed that when I put people on apixaban, say like for an SVT, for example, within a day or so, they say that the pain, that's the first thing they see, is the pain kind of diminishes. And then over time, the clot resolves very, very quickly. Have you all seen the same thing? Because I haven't seen that in the literature where people tout the anti-inflammatory effects of these meds, but I find there's significant pain reduction with the new oral anticoagulants.
So they all have that effect, and Lovenox and heparin the same thing as well, Peter. But you're absolutely right. These a lot of times, if a patient has an extensive clot, even though it's not a true axial SVT that we think about in terms of GSV and SSV, a lot of times if it's really extensive, I'll just give them a very low dose of Xarelto or Eliquis. 10 milligrams Xarelto, that usually will help with their inflammation, but definitely something to keep in your back pocket for sure.
Yeah, and Ken, you touched upon it just briefly about the length of anticoagulation. So the one trial that I talk about all the time is the WARS trial, in which they looked at Coumadin in people who are on the blood thinner for 6 months, 12 months, and 18 months. And they found that the patients who were on it for 18 months had a lower recurrence rate, but I've never seen that trial redone for the new oral anticoagulants. So that one example you gave of the patient who had a popliteal and a tibial vein DVT who at 3 months had turned to chronic. I usually tend to keep people on an oral anticoagulant for the popliteal vein for 6 to 12 months to give them as much opportunity to try to clear the vein, so to try to prevent them from getting post-thrombotic syndrome. So is the current recommendation that if it's chronic at 3 months that you can stop the anticoagulant?
So if you're going to go with CHEST guidelines, so the CHEST guidelines will say, you treat them for 3 months, but all of the studies, when you look at Einstein and you look at Amplify, Einstein extension and Amplify extension, those were done with patients on treatment for 6 to 12 months. And then they extended that prophylactic dose for 1 year. So the studies are there, but they're much longer than what's been recommended by CHEST guidelines in terms of treatment. But I think what you're doing, Peter, is exactly what the studies have done, which is the recurrence risk is significantly less when you have these patients on longer term therapy than what CHEST is recommending.
Yeah, and for the fellows, there's a study done by Paolo Prandoni in which he looked at patients prospectively with venography to specifically look at post-thrombotic syndrome, but he went back and he analyzed that original data set to look at what are the factors that were associated with poor clot clearance or recanalization, if you were. And at that time, everybody was being treated with warfarin. And what he found was that the people who had unsteady INR levels are the ones who had poor recanalization rates. And so that's another kind of piece of evidence to try to increase anticoagulation, the length of anticoagulation, to give patients an opportunity to have the greatest chance for recanalization, especially with the popliteal vein, since so many veins enter that one aspect, which is why the incidence of post-thrombotic syndrome is so high in that location. So I just a word of caution to the fellows, if you see a popliteal vein thrombus, if you're going to think of anybody that you want to extend anticoagulation on, that's probably the group that you might want to, as opposed to the femoral vein, which has very poor recanalization no matter what you use, and you get axial transformation of the profunda. So, but the popliteal vein seems to be the bad actor in terms of post-thrombotic syndrome. So does anybody else have any other questions? This was a really, really good talk. I could go on for hours on this talk.
I just want to make one more comment here, guys. One thing that I always stress to people who wind up observing or shadowing me in the office is that clotting is really, there's a spectrum, right? Your body is constantly clotting and dissolving all the time. And when we are doing our procedures, or when we're thinking about doing phlebectomies, or we're thinking about deciding whether to do that second, third, fourth vein, you got to think about what you're going to do to that clotting cascade. It's not just about closing the vein 2.5, 3 centimeters away from the junction, or 5 centimeters away from the junction with venous seal. It's about the balance between what you're doing to that cascade, and whether you're going to be using up all those clotting factors, and it throws your body out balance. So you see it all the time, right? People always say, well, there's no way that this DVT happened. It occurred in the lower leg. I did an RF in the proximal thigh. How did it happen? Or how did they get a PE? I had this awesome picture here. How can it be? And what happens is it all comes down to you throwing off the human body's clotting cascade, and that balance gets taken off. And so it's a very cerebral thing that you got to do. It's not as as objective as what you would like, but just keep that in mind when you're doing these procedures, is that they can have significant effects. And so the more you do this, you'll find that sometimes a perfect procedure won't always give you perfect results, or there's potential for complications, mainly because of these effects that we're creating.
Does anybody else have any questions for Ken?
Peter, I have just a minor comment. Ken, excellent presentation. As you, for the reason you just actually mentioned in one of your slides, I think we should not use the word superficial femoral, since the International Nomenclature Group has removed it very many years for the reasons of causing complication, because this is not a superficial, and I just saw it in your slide, and I think it should not be used at all. It's a femoral vein.
Yep.
Anybody else? All right.
Hey, happy holidays, everybody. Thanks for letting me.
Yeah, happy holidays, everyone. Fantastic talk.
Thank you.
Thank you very much.